Pericarditis. Pericarditis and other pericardial diseases result from acute or chronic pericardial insults, and these can lead to pericardial effusion. Pericarditis is diagnosed in 0.1% of hospitalized patients and 5% of the patient admitted for non-acute MI chest pain. Pericarditis is defined as inflammation of the pericardial sac. It can compromise cardiac output, and via tamponade or constrictive pericarditis. Most common idiopathic etiology. Other etiologies include TB, SLE, uremia, drugs, radiation, neoplasm. May also occur after MI, either within the days or after MI, or as a delayed phenomena, that is Dressler syndrome, or after open heart surgery. Any other form of injury can also lead to pericarditis. So the patient may present with pleuritic chest pain, dyspnea, cough or fever. Chest pain tends to worsen in a supine position with inspiration. The examination may reveal a pericardial friction rub, elevated JVP and pulsus paradoxus. A decrease in systolic pressure, BP of more than 10 millimeters or inspiration can be present with tamponade. Diagnosis can be done by X-ray, ECG, echocardiogram to rule out MI and pneumonia. The ECG changes include diffuse ST segment elevation and PR segment depression followed by the T inversion. The pericardial thickening or effusion may be evident on echocardiography. The treatment, one has to address the underlying cause, as for example corticosteroid, immunosuppressions for SLE, dialysis for uremia, or symptoms as for example ASA for post-MI pericarditis, ASA NSAIDs for viral pericarditis. One has to avoid corticosteroid within the few days of MI, as they may predispose to ventricular wall rupture. Pericardial effusion without symptoms can be monitored, but the evidence of tamponade requires pericardiocentesis with a continuous drainage as needed. Prognosis for acute idiopathic pericarditis, good long-term prognosis, and the cardiac tamponade is rare, but up to 70% of the cases with specific etiologies, as for example neoplastic, tuberculous, or prurine. The constrictive pericarditis occur in about 1% of the patient. 15 to 30% of the patients not treated with colchicine develop either recurrent or in-season disease. Recurrent pericarditis, the exact recurrence rate is unknown. Most cases considered to be autoimmune. The risk factors are lack of response to aspirin, either NSAIDs, glucocorticoid therapy, inappropriate pericardectomy, and the creation of a pericardial window. For some of the patients, the symptom can only be controlled with steroidal therapy. Autoreactive pericarditis, the diagnostic criteria include pericardial fluid revealing more than 5,000 per millimeter mononuclear cells, or anti-sarcomere antibodies, sarcolemmal antibodies, inflammation of the epicardial or endomyocardial biopsy by more than 14 cells, exclusion active viral infection, both at the pericardial effusion or endocardial epicardial biopsies, exclusion of tuberculosis, Borrelia burgdorferi, chlamydia, pneumonia, and other bacterial infection, absence of neoplastic infiltration in effusion and biopsy samples, exclusion of systemic metabolic disorder and uremia. Treatment include aspirin, NSAIDs, colchicine, glucocorticoid, immunosuppression including azathioprine, cyclophosphamide, mycophenolate, methotrexate, IVIG, pericardectomy to avoid poor wound healing, and recommended to be off prednisolone for 1 year, and reserved for the following cases if more than one recurrence is accompanied by tamponade. If the recurrence is principally manifested by persistent pain despite of intensive medical trial, evidence of the serious glucocorticoid toxicity.